Now, fine, as such, dizziness itself is a very non-specific term. And frankly, when we sit in our clinical practice, we encounter so many conditions. Many times even an epilepsy and the psychiatric causes. And the rest, whether it is syncope or disequilibrium, represents 25% of those cases. So that was one point that my ENT friends should remember. There is another point which is worth remembering is that almost 20% of the cases with peripheral vertigo, they have another cause of dizziness. So you have treated one, let us say Meniere's or XYZ, and still the patient might have some complaint, one or the other. And he might be one of these cases. And a lot of different permutation combinations are seen in the clinic, but the most commonest that I have seen are these two. The migraines with Meniere's and migraines with benign peripheral vertigo. So I think so these two messages are very important. 40 to 45% of the cases might. Now vertigo is defined as an illusion of movement. So movement is not there, but the patient feels there is some kind of movement there. The movement can be anything. It could be spinning kind, it could be rocking, it could be a tilting, it could be a sinking feeling. So all this comes under definition of vertigo. And when there is no sense of motion, but there is a spatial disorientation, that comes under the definition of dizziness. So now things have become much simpler. When there is a sense of illusion, it is vertigo. And when there is no sense of motion, it is dizziness. So the scheme of things, whenever we see a case of vertigo, are these four questions. First, is this dizziness a vertigo or it is dizziness? The first and the simplest question. And if it is vertigo, the second step that comes to the mind is this vertigo central or peripheral? If it is peripheral, means the vestibular system and the vestibular nerve, the localization goes there. And if it is central, the localization goes to the brainstem and the cortex. So the second step, with that we come to our working diagnosis. And with the working diagnosis, the differential diagnosis obviously comes along. So we investigate the patient accordingly and confirm the clinical diagnosis. My scope of today's talk is the first two steps. Is it vertigo? And if it is vertigo, whether it is central or peripheral. And what could be the differential diagnosis? My next speakers would take over from here. Now, these are certain approaches which are mentioned in the textbooks. The titrate and the attest. These are the acronyms for different things. But frankly, as a neurologist, I don't like this approach. We usually go into a detailed history and the examination, and we form a pattern of a patient. And fortunately, the International Classification of Vestibular Disease itself recently has promoted the similar kind of classification. Now they recommend these three different kinds of syndromes: the acute syndromes, the recurrent syndromes, and the chronic syndromes. Now let me give you one or two examples of them, and things would become more simpler. As for example, a 50-year-old male comes with history of vertigo, with nausea, vomiting, with or without loss of hearing, with head impulse test positive. The duration of vertigo is maybe days to weeks. So the diagnosis straight away goes towards vestibular neuronitis. And a similar case, let us say a 50-year-old male with vertigo of few days to week, non-diabetic and hypertensive, but has along with maybe dysphagia, dysarthria, visual field defects, that tells me that something is wrong in the brain. So we have a case of acute syndrome, wherein the presentation can be a vestibular neuritis, or something is wrong with the brain stem, maybe posterior circulation stroke, or a demyelination, or maybe even a drug-induced. So this is how you take the syndrome and form a differential diagnosis out of it. Similarly, the case of, let us say, a patient has recurrent vertigo. When the patient has recurrent vertigo, the differential diagnosis even becomes vaster. Just I'll give you an example, the detail will be taken by Dr. Srinivas. Now, as for example, a patient has multiple attacks lasting for few seconds, very much like neuralgia. He might be dealing with vestibular paroxysm. Or if a patient has recurrent attacks but lasting for a few minutes, which is aggravated by posture, it becomes benign paroxysmal position. If the attack lasts for maybe hours to hours, then probably I am dealing with vestibular migraine or vestibular Meniere's disease. So this is how you can form a differential diagnosis depending upon the type of syndrome that we are dealing with. And lastly would be the chronic one. A patient has gradually progressing or maybe a chronic sense of imbalance, vertigo, with or without other symptoms. We might be dealing with phobic PPD, with phobic perceptual dizziness, or we might be dealing with a gradually progressive structural lesion coming up in the brain, which is increasing over a period of time, like tumors, or it could be just a benign condition like Marley and Parkman kind of syndromes. So in nutshell, we go to the history and the clinical examination, and we come down to these three syndromes, and from those syndromes, the differential diagnosis takes over. This is the way we usually approach. I have already mentioned about the history part, but these are few points which are relevant in the entire practice of medicine are followed in the history taking. A description of symptoms which will tell us whether it is vertigo or dizziness, the onset and the progression. As for example, a thing which is probably neglected is, let us say, a subacute progression. An acute is simple, probably vestibular neuritis, stroke. A chronic or a slow progressive is simple. But as for example, there is a subacute onset over a period of few days to weeks. We might be dealing with something like autoimmune disorders, which are recently a new concept has been coming up: steroid responsive, subacute progressive, autoimmune and paraneoplastic syndromes we might be looking at. Similarly, I already mentioned about the duration, whether it is for seconds, minutes, hours, days, and maybe even years. And that is how you can easily formulate a differential diagnosis. The associated symptoms. I think we should pay a lot of attention to these associated symptoms. Like abrupt loss of hearing can be both in labyrinthitis as well as in posterior circulation stroke. But there are certain simple pointers which tells us that the lesion is in the brainstem. And there are simple pointers like the vertigo increases with the motion of the head. With the head motion tells me that this is a vestibular disorder. So simple associated factors and aggravating factors, presence of visual loss, dysphagia, dysarthria, ataxia, behavioral problem, all these things would tell me that probably I am dealing with a central pathology. So, and lastly is the medical history. Please take the medical history along with it. There are a large number of drugs. Here, probably everybody encounters it. कि सर तुम्हारी दवा बहुत गर्म पड़ी. This could be one of those indirect way of manifesting that. I am having dizziness because of your medication. So always whenever the patient says that તમારી દવા બહુ ગરમ પડી કે ચક્કર આવે છે, do take a good medical history out of it. Now we come to the core part, which is probably the most time consuming and the difficult one. Frankly, when I met Dr. Srinivas in the morning hours and saw his DNG and stabilometer, I thought that I am spending so much of time on this much of clinical examination, which could be easily, with good history, VNG and stabilometer, large part of my problems can be sorted out. But fair, we don't have any of those machines, so we have to go clinically. So whenever we get a patient of vertigo or dizziness, in addition to neurological examination, these are the things which we do as a clinician. We observe the eyes, we do the hints and hints plus test, we add ataxia grading whenever there is an acute vertigo. I will go into details of them one by one. And whenever we have a positional vertigo, we add Dix, Hallpike and the control test. And whenever we have bilateral vestibulopathy, we add the dynamic eligibility test and sharpened Romberg's test. That is what you do at stabilometer. That is what I realized. So this is the clinical setup. And with the help of DNG and stabilometer, what I realized was that there are 2 or 3 advantages of that. First, you can document it. Whatever I am seeing clinically is one thing, but you can document it on the DNG and stabilometer, what are the clinical findings. And second, the advantage is obviously it saves time. Your technician does large amount of that job. So these are the 2 obvious advantages of the machines that we have now. Now let us go one by one. I would like to add one more thing. Neurological examination includes examination of gait. So for ENT people, that might be an extra line. Examination of gait in patient of vertigo should be an extra stuff. Now coming down to the examination of eyes, we basically look into 3 parts: the resting, the pursuits and the seconds. And I'll just show the videos of all of them. I've just collected short videos of all what we see around. This is I'll just show you 1 or 2 videos and then we'll go into the in resting eye movements, we observe the patient for 5 to 10 seconds and we look for any abnormal movements of the eyes. And we basically look into 3 aspects. One is the square wave jerks, second is the ocular flutter, and third is the obsoletus. First we will see the videos of all the 3 and then I will explain you. These are square wave jerks. They are just very slight movement of the eyes, and this is a physiological. A person would deviate his eye here and there. Can you go to the next video? This is an ocular flutter. These are horizontal movements. Square wave is also horizontal, but there is 1 or 2 minor movements. These are rapid, jerky movements horizontally. So these are again horizontal movements, but they are rapid, jerky, all of a sudden coming up. And these are ocular flutters. Can we have the next one? Volume बंद कर दीजिए. When it is multi-directional rapid eye movements, it is called as opsoplonus. बस ठीक है. Now can you go to the slide, first slide? First slide. Back. Slide. First slide. Fine. So now we in the resting eye movements, in the resting position we saw three rather movements, and they are called as saccadic intrusions. The first one was square wave jerks, mild horizontal movements. They are physiological. Any anxious man can have those square wave jerks. With VNG and with the goggles, you would see these kind of movements more and more. The ocular flutter and opsoclonus, these are suggestive of brainstem disease. And more commonly seen, which as I mentioned before, the autoimmune encephalitis, which could be paraneoplastic also. And these patients need immediate work for that. So this is what we see in the resting eye. Now we go to the pursuit and the saccades. Next videos. From video 20. Yeah. This is regarding the pursuit movement. Pursue is part, you move slowly on an object. And you see the smoothness of the eye movements when the movements are done slowly. So these are the pursuits. Can we have the next view? Saccades are rapid eye movements. Pursuit is a slow movement. Saccades are rapid eye movements. Shifting between two different So this is shifting your vision from one point to the another, and look at the rapid eye movements. Now anything abnormal in the pursuit in the saccades tells you are dealing with the central disease. Vestibular system doesn't involve the pursuit and the saccades. So till now, opsoclonus, ocular flutter, abnormal pursuit and saccades, you are dealing with the central disease. Whereas square wave jerks, you are dealing with normal phenomena. Yeah, this is the same saccades seen on VNG and the goggles. Fine. Now the next. So this is how we see first the eye examination. And the second step, which is probably the most crucial, is the hint and hint plus. Hint stands for head impulse test, nystagmus, and skew deviation. You do these three tests together is called as hint test. This test is extremely useful. This combo is extremely useful in localizing whether it is a central or a peripheral disease. And mind you, the sensitivity of hint is almost 97 to 98%. So still with hints, you can miss 2 to 3% of cases of strokes, despite of doing hints. And to add to the problem, MRI can be normal in 14% of the cases with stroke in first 48 hours. So it becomes extremely important to understand that there is a good chance of missing a posterior circulation stroke by 2 to 3% with normal MRI. So what we have added extra to it. When you add hearing to it, an acute loss of hearing, that is called as hint plus. So we add head impulse, nystagmus, skew deviation. I will elaborate them. And if you add acute loss of hearing, that brings the sensitivity to 99%. And if you add the ataxia grading, the sensitivity becomes almost 100%. So the chances of going wrong or missing a posterior circulation stroke with hints plus and ataxia grading is practically zero. Another thing which I have realized and later on I saw in the textbook also, It takes time to learn doing Hind's test. You have to do it in so many patients to gain the confidence to understand it. It's very much individualized. हमारे सीखना पड़े वारंवार करेंगे. And hence I believe that the residents, those who handle the emergencies of hospitals, should be taught hands-on with Hind Plus so that they don't miss the posterior circulation strokes. This was just to add the ataxia grading. It is very simple. If a patient can stand and patient can walk, it is grade 1. If on standing I am wobbling, but I need support or help to walk, is grade 2. And neither I can walk independently nor I can stand independently. It is grade 3. And mind you, grade 2 and grade 3, it is same. So another point you can add to your armamentarium is grade 2 and grade 3 of ataxia. You are dealing with the central motor. So my take, whenever a patient who comes with an acute vestibular syndrome are these three. I do the Hind Plus, ataxia grade, and I get the MRI, which makes me 100% sure that I'm not missing a catastrophic posterior circulation. This would be another take-home messages for all physicians and here. Now, I've already mentioned, okay fine. I'll now show you a few videos about Hind and then I'll explain you about them. This is head impulse test. Fine. In head impulse test, I don't know how many of you have been doing head impulse test or not, but the head is rapidly turned in one direction, around 10 degrees, and my eye would move equally and opposite in the opposite direction. But if my vestibular system is not normal, even if my eyes move, I move the head in this side, there will be a corrective saccades to push the eye to the left side because my vestibular system is not working well. આ વિડિયો ફરીથી ચાલુ કરશો with audio. Now when head is moved here, there is a corrective phase of nystagmus coming. Can you repeat it please if you don't? અને audio ચાલુ કરજો સર. The head is turned to the right, there is a corrective second. एक वक्त छेड़ी होकर. I don't know how many of people, I hope you are getting it.
Yes.
Yes. Turning the head to the right, there is a corrective phase to the left. There it is. That is head impulse test positive. And that is suggestive of an abnormal vestibular system. So positive head impulse test is a sign of peripheral vestibular disease. The next one. The next is the nystagmus. First was the head impulse, the second is nystagmus. Presence of nystagmus by and large means something has gone wrong in the vestibular system. And the nystagmus are classified as pendular. There are multiple types of classification, but the simplest is the pendular versus jerk. In pendular, both to and fro are equal. And in jerk, what we saw in the head impulse test, there was a corrective phase and there is a slow phase. And the nystagmus is named after the corrective phase, the rapid phase. So if I have a corrective phase to the right, I have a right beating nystagmus. If the fast phase is to the right, it is called as right nystagmus. If the fast phase is to the left, it is called as left nystagmus. So I will show you different kinds of nystagmus and then we'll come further back. Ghost, hello. Videos बताए. Next. Right. These are bilaterally equal to and fro movements. These are pendular jerks. annular nystagmus. I hope it's clear.
Yes.
Right? By that these are congenital or near birth and they are fissure, we can't do anything about it. Fine. The next. Now we are looking at the jerk nystagmus. This is downbeat nystagmus. I hope it's very clear. I hope it's clear. Right? Next week. Now these are the upbeat nystagmus. Whether they look to the right, whether they look to the left, the nystagmus is always upward. I hope it's clear. Fine. Sure. Now, whenever you see a vertical nystagmus, whether it is a downbeating or it is an upbeating, you are dealing with the central cause. Downbeating is more common, upbeating is less common. But by and large, you are dealing with a CV junction or a posterior fossa anomaly. So, presence of a vertical nystagmus, more so with the down, straight away MRI posterior fossa should be there. Now, coming down to the horizontal nystagmus. Now, horizontal can be both peripheral and central. Now, you have to understand the definition of unidirectional versus bidirectional nystagmus. Bidirectional एक इसको फिर से चालू कर दो. Bidirectional means when I am looking to the right, the fast component is beating to the right, and when I am looking to the left, the fast component is moving to the left. And in unidirectional nystagmus, if I am looking to the right, the nystagmus is moving to the right, and even if I am looking to the left, the nystagmus is to the right. That is unidirectional nystagmus. Okay. So even with the change of gaze, the direction of nystagmus doesn't change in unidirectional nystagmus. And in gaze evoked nystagmus, to the right, the nystagmus is to the right, and to the left, the nystagmus is to the left. Anapelana video. Fine. This one. You see when the lady is looking to the right, you see a right gaze nystagmus. Can you see? Right? Now she is looking to the left. The nystagmus has shifted to the left. एक बार फिर से repeat कर देते. Can you see the change in direction of the nystagmus? Bidirectional horizontal nystagmus is central nystagmus. Is that clear? Bidirectional horizontal nystagmus is central nystagmus. Next. This is nystagmus to one direction. So horizontal unidirectional nystagmus is peripheral nystagmus. This nystagmus is to the right. Fine. Next. So, एक स्लाइड आगे છે और આ વિડિયોઝ ની પહેલા So what did we learn in nystagmus? A unidirectional nystagmus, horizontal and torsional is peripheral. A vertical nystagmus and bidirectional nystagmus is central nystagmus. But in nystagmus you also see few other things. That is the latency, fatigability, adaptability and suppression. I'll explain you what exactly do we mean with that. When you turn change the position, and the nystagmus would start after 3 to 5 seconds. That is the latent period. Is peripheral. So presence of latent period before the onset of nystagmus is peripheral. And you keep the position of the head in the same position, one position And over a period of time, the nystagmus fatigues. It reduces in intensity and severity. It is peripheral. And you do it again and again. The nystagmus goes down. Your CNS is adapting to it. The brain is adapting to it. And you can suppress it by vision. You can suppress it by the cortex. So these 4 points also we look when we are looking for nystagmus. Presence of latency, fatigability, adaptability, and suppression. All of these are features of peripheral. I hope I have tried to simplify nystagmus to the maximum. Fine. And now the last part. We had head impulse test, we had nystagmus, and now we go to the skew deviation. Jawad wala videos mo. Fine. Next, sharpen rhombus. You see, skew deviation is the vertical malalignment or misalignment between the two lines. And that is usually central. And the best way to do is cover-uncover test. This is old time. What I do is clinically only. Ek arm cover karo, look into the movement of the other eye. You cover the second eye, look into the vertical alignment. So presence of a skew is central. And absence of skew, just touch. Absence of skew is peripheral. So abnormal head impulse is peripheral. Absence of skew is peripheral. I like this video because it summarizes very well all the 3 aspects of head impulse test. It is fast one, but within 30 seconds it summarizes all the 3 aspects: the head impulse, the nystagmus, and the skew division very well. Isko chalo. ये वीडियो आगे charge basically there it is. This is normal. This is corrective seconds of head impulse. This is bidirectional. This is unidirectional. This is peripheral. This is central. And this is the skew deviation. No skew deviation. Peripheral. And you add the hearing part to it, that becomes hint plus. So this is how we basically, next slide. Sharpened rhomboids, I think so. Okay, fine. Let me show the video. Unaudible. Okay, fine. Basically, when you suspect a patient with bilateral vestibulopathy, where probably bilateral head impulse test is positive, we can do one simple bedside test which tells us that this is bilateral vestibulopathy. Normally, rhomboids test where we do legs, eyes closed. If the patient has sensory loss, patient will be wobbly. And sharpened rhomboids is that you make it head and T standing like this with eyes closed. A normal person will be able to stand more than 6 inches. If a patient has bilateral vestibulopathy, this is called a sharpened rhomboids test. With eyes closed, they will not be able to stand for 3 to 5 seconds also. I know bilateral vestibulopathy is a difficult diagnosis unless and until you know the clinical aspect of it. So that's why I did not want to show sharpen, but this is a bedside test which can be of great help for bilateral vestibulopathy. And now probably the last 2 slides. Now I made the summary of all central versus peripheral. Historically, from history, if there is a lot of vertigo, a lot of nausea, vomiting, you are dealing with the peripheral vertigo. If there is a lot of ataxia, patient cannot stand, central. Hearing loss can happen in both. If there is a stroke in ICA territory, anterior inferior cerebellar artery, you will get a hearing loss, but not in pica or the other strokes. And if there are central symptoms which I mentioned before, dysphagia, dysarthria, ataxia, it is central. And on examination, the last line, presence of flutter and opsoclonus, central. Head impulse test positive, peripheral. Presence of pseudoevasion, central. And present in nystagmus, if it is unidirectional, with latency, fatigability, adaptability and suppression, we are pretty sure that we are in peripheral. What I hope with this, my scope of talk, where you can differentiate between the two. Thank you for your patience.
Trying to cover a bit of anatomy also. So let me start with the anatomy. There are set protocols for posterior fossa and temporal both lesions whenever they are asked for. In the CT, it has to be subcervical sections, serial sections, and then it can be with the bone reconstruction. It can be reformatted in coronal and sagittal planes. And in MRI, preferably in the conventional images, 4 mm section thickness is preferred. Addition to that, we need heavily T2-weighted images for looking for inner ear structures and for the labyrinthine structures. Fine. Next slide, please. So what we see here, this is a T2 weighted images. The posterior fossa includes cerebellum, midbrain, pons, medulla, and 7th nerves, cochlea, semicircular canals. Next slide, please. With the fiesta or heavily T2 weighted, previous slide. Heavily T2-weighted images, what we see is cochlea, semicircular canal, 7th, 8th nerve. So 7th nerve will be seen in the higher cuts, cranium. So from caudal to cranium if we go, this is the inferior division of vestibular nerve, this is the cochlear nerve, this is the cochlear nerve at the level of lateral semicircular canal, and when we come cranially, we see the superior division of vestibular nerve and the facial nerve. And we can reconstruct the semicircular canals and cochlea. With CT and MR both, we can reconstruct the next slide, please. So this is how it's seen. The facial nerve, the superior vestibular nerve in the sagittal reconstruction, facial, superior inferior division of the vestibular nerve, cochlear nerve, and here what we see is the osseous spinal lamina, basal down of cochlea, which is seen better on the MRI scan. This is a modulus. This will be seen as white or calcified in CT scan. Next slide, please. 1.5 Tesla image. 3 Tesla image is required when we are thinking of Meniere disease diagnosis, and we require. So what we see in CT scan now, from caudal to cranium, at the level of cochlea, this is a basal nerve, this is a facial nerve, and this is the carotid nerve. Next slide. You can get the left of ear image. Now coming to the level of tympanic what we are seeing here is the membrane of the malleus. Coming next, this is the malleus and this is the incus. This is cochlea. This is the basal gum, and what we are seeing here is the window. This is at the level of oval window. What we are seeing is around 70 to 80% of the cases in sub-millimeter size, we should be able to see the cells. And this is the cochlea, this is the molluscus. Here, what we are seeing is the edge of the malleus. This is overview. This is cochlea. And this is the starting of the canal. This is the impact motion of the cerebellum. So from here it comes like that. The area of same level you see the level like this, and in this short process, and then this is the isolated bone at this. This is one level above what we are seeing at the level of internal oriented canal. This is the cerebellum which is going immediately into the genital canal, going posteriorly, like this it is coming back. This is malleus, this is incus, and this is at the level of antrum. So the same things with the coronal scans. This is the area of the genital canal, where we see both outline of the cochlea. This is malleus and incus. This is the posterior, and on the medial side, the malleus is anterior, and it is about to the implantment. So this is the cochlea. What we see here is the anterior and posterior portion of the cochlea. This is the picture now in the coronal scan, anchoring into the lateral, and this is the overview that is just about that. Just about that is the semicircular canal. This is just about that, and so superior semicircular canal. Yes, with the vertical motion of the or muscle induction of this facial nerve which comes out to the diagnostic. So we have discussed the causes of the commonest is BPP, where we don't find anything on cellular MRI, but the rest of the things on the MRI and CT scan. So what should we ask for? The combination of CT and MRI is the best. Then everything is about the symptoms. We can ask for MRI or CT scan. MRI is usually preferable for vertigo, and CT scan is preferable for patients. In the second problem, what we see is averages, groups, little changes in the weather that is involvement of labyrinth, first infection and multiple sclerosis, which is also one of the this survival vertigo usually will be found at MRI. So MRI is preferred over CT, but the combination is always the best. Coming to malleus disease, nowadays a lot of researchers are going for malleus disease. Little bit in the is too much, but I think we should be able to use this. What happens in median disease is there is increase in the pressure of endocardial blood. Usually, this is the ventricle, this is the saccule. Saccule is not seen on MRI, and ventricle is seen. What happens in eye drops, the saccule occupies whole of the vegetables. So this is seen on the MRI or higher, where the specific sequence articulated leg is required, but the procedures which we use, because IV contrast needs to be administered at least 2 to 5 years back prior to the examination. Some people have also tried direct injecting contrast into the ear, but that takes at least a day to get it introduced into the brain. So what happens is normal cuticle is seen that occupies around 50% in the vestibule. But as the dihydroids or in the fingers, the cycle fills up the anterior and posterior almost whole vestibule, and the cochlear nerve does that. So the net effect is alternate white blood as which I will show you. So this is a normal appearance. This is a normal appearance. So what happens is when we give contrast, it gets reduced into the semicircular canal, which includes internal auditory canal. So this white thing what we are seeing is the diffusion of the contrast. The black thing is the endolith where the contrast has not. So this is one case where we can see here the negative cycle, and at the same time the black thing we are seeing here the endolithic ducts which are not satisfied with the contrast. So here this is the vestibular area which is almost occupied by the dilated cycle. So here we don't see any contrast. The same thing is very difficult to see in conventional images, that is TV image or PSR system all the patients when there is a requirement of the posterior fossa series. So this is a case where this is a normal epiphanitis. As this dilates is occupied the ventricles, it looks like a black hair because it is not broken contrast on the side, and the alternate band of white black is in the cochlea. Because perineum gets opacified and the endolith does not get opacified because of the pressure. This is a simple heavily integrated image where we are not able to find endolith. This is the post-contrast evaluated image. What we see is this side the contrast is opacified, this side is this. But these two images are the flare, subcentimeter size, the staining flare image will be after 4 hours of the contrast, highly contrast. So here we are seeing only little bit of this, and here what we see is the coming to perineum package, there is a this communication between one of the semicircular canal or vestibule with the megalia channel. So this you can see this is the perineum package. Another indirect sign for the perineum package is to see hair, because megalia has a lot of hair. So what we see, if we don't find the direct communication, we try to look at the hair within the labyrinthine structures. Hair looks black both in CD and MR. Here we are able to see black hair, here we are able to see black hair in the vestibule. This is another case with the cochlea. Semicircular canals, cochlea. We are seeing here, this is an indirect sign for the perineum. This is normally over window, where you don't see contrast diffusion. Here what we are saying, this is sonography, where we are seeing the contrast coming to the over window. Labyrinthitis is an inflammation of membranous vessels, where this in-situ images we don't see anything. This is the conventional cellular images is stimulated. But when we give contrast, here this is the lateral semicircular canal, this bottom enhanced because of the inflammation. Meningitis also many times get extended into the 7th, 8th nerve complexes. This is the case where you can see the meningitis ventricular line getting enhanced, and this is the critical nerve which is enhancing. This is the case of meningitis, and here we can see left sided 7th, 8th nerve getting enhanced. The same thing you can see any leptomeningeal disease. This is the case of the leptomeningeal carcinoma. What we see is a potent enhancing soft tissue in the region of both internal and external. This was another case of meningeal sarcoma where we are seeing here the enhancing dura along the sutures, involvement of the cerebellum as well as middle cerebellar together. There is a small amount here of the enhancement. This is around 7 millimeters. Coming to vestibular neuritis, once again we need post-contrast study, and post-contrast study whenever we require it for the posterior fossa, we need to have a TV image because they are too small and they need to be compared with the opposite side. So here what we are seeing is the enhancement of the cerebral nerve complex, and this side there is no enhancement. This was a case of Ramsey and syndrome. What we are seeing here is the 7 up we call it posteriorly and superiorly. The 7 now is enhancing, and opposite side is not showing any enhancement. Coming to vestibular schwannomas. Vestibular schwannomas, whenever they are suspected, once again posterior fossa protocols required with the system with the contrast study. Here outside what we see here is small schwannoma in the internal abdominal canal. Here there is little bit division of the outside of the canal. The same thing is enhancing. When they become larger, they have a screen bone appearance. The schwannomas usually have internal necrosis, hemorrhage, and heterogeneous enhancement. This is how they look. The differential may be with the meningioma, where they don't go inside, and the enhancement will be homogeneous without any hemorrhage, and they will against the meningioma. This is another case where we are seeing the meningioma here and the schwannomas here. This was a case of epidermoid and CT angle elements is aligned, except when we see the image which shows epidermoid being right. These patients may have presentation of failure of the lower cranial pulses and symptoms of irritation. Coming to cholesteatomas, this is a collection of keratinizing squamous activity in the middle nerve. What we see is if there is a bone resorption, then we call it as cholesteatoma, but it is very difficult for radiologists to differentiate cholesteatoma versus chromocytopenia. It's a clinical diagnosis. And whenever we see some soft tissue in middle ear cavity, sometimes it may be very difficult for only on the basis of metacity to differentiate between small clones. We need to go for contrast study to see the brightness, bright enhancement and other patterns. Only on the basis of CT scan, what we see, we can tell is a soft tissue within the middle ear cavity, erosion of or ossicular shield or not, or whether there is an involvement of the labyrinthine structure or not. So, what we see here is this is also post-operative case of the cholesteatoma. There is a communication of soft tissue with the lateral semicircular canal. This patient had a dental vertigo. This is a case of chronic vasculitis where we can see the erosion of the muscular system. This is another case where we can see the communication with the lateral semicircular canal. Cholesteatoma has a peculiar appearance on MRI, looking as a bright structure on diffusion images. They do show diffusion restricted by posterior epidermoid and anywhere else in the body. They show the same thing. So whenever the cholesteatoma surgery is being done, and then there is a question of whether there is some residue or not, ask for MRI because diffusion images may help to Autosclerosis is very difficult diagnosis for the radiologist because usually it is a bilateral and there is some small lucency out here, just a window, oval window, we see this on both the sides. Most of the time they are bilateral, that is why it becomes very difficult to start with, to begin with. Once they are established, you can see here this whole photosphotograph, the whole is what we are seeing the ragged margin of bladder semicircular canal, even cochlea is not seen very well. This is the case of photosphotography. In trauma, whenever there is a hemorrhage in either their cavity or in the tympanic cavity, we try to look for the fracture line which is going through that. Try to look for the dislocation of medium vascular chain. So, like this, here this patient had a deafness, but what you see is the longitudinal fracture which is passing through the vascular canal. This is another longitudinal fracture. The patient now has. This is the transverse fracture, what we are seeing in the involvement of the patient. Labyrinthine ossification is a sequence of chronic bronchitis with chronic mastitis. What we see here is when we make out all semicircular canals here, this side it is not. So sometimes patient directly comes to the MRI, there's a time if we run this once we come to know that there is some problem here, we ask for the CT scan. Usually most of the time the radiologist who is doing will ask for CT scan, but it is better if the combination of both. Sometimes what happens is this is a case of malignant bronchitis externa. We feel that there is some sort of involvement of lateral semicircular canal. So soft tissue here gets merged with this. At that time, very difficult for us whether there is involvement or not. But in that case, if we see run cyst reading, we will see in that of CSF, most likely it is not. Now coming to the single point, the most common is most of the time it is very difficult to find the small impasse in the medulla. So I have run a protocol that whenever the symptoms come, the patient needs to go for the coronal division imaging also. So many times if we miss this, because in MRI they take section at 10 mm difference. So the 10 mm small 5 mm impact will be missed. So this posterior fossa coronal or sagittal, subcoronal is better because in that everything will be able to see. So that this is how we don't miss out any posterior fossa impacts. In my practice, I have seen many of them after doing this the coronal diffusion images. Hemorrhagic areas will show blooming or more profound hyperintensity or greater this. So this is one case. This patient came with the vertigo with the right node in weakness, and then what I could see is there is some hyperintensity here. This is a diffusion area. At the same time, you can see this left vertebral artery, right vertebral artery. We are not seeing the flow. So the right vertebral artery there was a confusion. Sometimes just two vertebral arteries, they go one hypoplastic and one we don't know whether it is a hypoplastic one or whether it is a thrombus. Better to look for detail on this. It will make us help us to see the diameter, to help us to see what's there inside. Alright, it's not the thrombus is there. For example, in this, even though this is a non-dominant system, there is a thrombus in this. This is a case of right vertebral artery right hypertension. Vascular loop syndrome, there are a lot of controversies with this, but the one thing which is proven so far is for the fifth node. Within 1.5 mm of exit zone, the vascular loop causes trigeminal. Sometimes it causes vertigo also. For seventh node, hemifacial spasm, the vascular loop and the for the glossopharyngeal neuralgia, the loop and the exit angle of the glossopharyngeal. The ICA, this is the The alpha loop responsible for vertigo or silent symptoms is a controversial issue. There are three types of alpha loop. One which is near the IDC, one which goes after the IDC, one which goes. A lot of studies have been done, but nothing conclusive has come out of as of now whether they are responsible or not. Coming to multiple sclerosis, where we see multiple patches of tissue either intensity in posterior fossa as well as in the cerebrum. These are things where patients presented with the posterior fossa symptoms. What we are seeing is small MS plaques outcome, and this is active when it is going to the regulatory system. Fourth particular are also or lesions, they can also present later vestibular symptoms. This is a case of this patient had a history of headache and giddiness. And what we found here is something in the foot, and we can find out there is something out here and there is small swelling out here. So cystic image has shown this is the intraventricular fibrosis cells. The same thing epidermoid, fourth particular epidermoid. Epidermoid has specific characteristics of being bright on the different models. Contact tumors in children present with walls, giddiness, lower cranial opacity. This is the UPI image where we are seeing the right-sided tracts being destroyed. The cerebellar SOLs, what we are seeing here, large right cerebellar tumor, this patient had headache and giddiness, that was one of the symptoms. Spectroscopy also we can run through, but it helps in only few cases. Inheritances that will be infused fully
role of surgery in vertigo, especially in Meniere's disease. So, surgery and vertigo usually does not go together, and physically it is a majority of cases it's a medical disease. But the role of surgery cannot be 0%, and it cannot be more than 1%. So if you are seeing huge cases of vertigo, there will be some patients who will be frustrated with their vertigo, who will be having very poor quality of life, and those patients will be mostly having recurrent vertigo. Single episode of vertigo for 15 days will never cause any problem to patient. So such patients mostly are of Meniere's disease. So what we will discuss today is more of Meniere's disease, but it applies to many things more than Meniere's disease. And at the end I will discuss other surgeries. So first we will just understand how is the role of surgery and how the vertigo happens. So vertigo always happens when there is a peripheral disturbance, asymmetrical vestibular activity. So if any single side of vestibular system becomes abnormal, then there will be asymmetrical information to brainstem and cerebellum, and that is what will cause peripheral vertigo. I am not talking about central vertigo, but so this is just an animation. What happens during most of the acute vertigo, like acute vestibular neuritis or acute labyrinthitis, we lose suddenly input from one side. So what we get is a nystagmus towards normal side. So that above picture shows nystagmus, and right, nothing. So normal vestibular system and abnormal vestibular system will, as discussed previously, will cause nystagmus towards normal side. So thankfully God has given central compensation. So whenever this happens for one-time disease, our central system, including brainstem and cerebellar clamping, will come into action, and what it will cause is central compensation. So all the acute one-side episode, vertigo, we don't need surgery because God has created a mechanism for that. And we just have to do vestibular rehabilitation, give them good compensation, and they are of first 3-5 days they will require medicine, then they don't require medicine also. So our role is just to help God's compensation, central compensation by good vestibular rehabilitation. But what happens in certain diseases, the abnormal side tries to recover again. Like it happens in Meniere's disease, like it happens sometimes in migraine. So this is now coming, going. This is paroxysmal vertigo, repeated episodes of more than 15 minutes to 2 hours. And this happens every time the endolymphatic hydrops rupture or every time the migraine happens. So this time again what compensation had happened again, it will, sorry. So what compensation has happened, again it will happen on the opposite side. So now the nystagmus will be beating towards the affected side when it is compensating. So it is after 12 to 24 hours of Meniere's disease, the system will change. If this would have not come back, our problem was solved. Because it is coming back again, it is fighting back, it is trying to recover, then the patient recovers completely in 20 to 24 hours. After 24 hours, he becomes completely asymptomatic. He becomes like he never had any disease. This is good for 1 or 2 episodes or 1 or 2 episodes in a 6 months, 1 year. But when the disease progresses, this starts happening every month and slowly every week. So that is when the quality of life starts getting affected. So if we know this mechanism, we know what is happening to the patient of Meniere's disease. His disease is not allowing him to compensate. His disease is not allowing him, his central nervous system to come back to normal. He has a strong central nervous system which can make him normal, but because the disease is coming back again and again, he is having problem. So we have to discuss with patient. This is the first thing, like if the patient has enough episodes of Meniere's disease, we need a very healthy discussion with patient. How is the disease, how it can happen over the next 1 year, 2 years, 5 years. And we have to give him lifestyle modification, everything Darshan Bhai has elaborately explained. We have to start acute vertigo attacks for 1 or 2 days. We may help him with acute medicine and then maintenance therapy with beta-histine and Dimox. So once the diagnosis of Meniere's disease, definite Meniere's disease has become, patients should know that this is not a short-term disease. This is not a disease for 1 month or 2 months. It may go back for 5 years, 10 years, but it may come back. So patient should know now the whole scenario of his disease. We have to explain him that this is how your disease is going to behave, and don't worry, we have a solution for it. If you tell them from first day, instead of writing only medicine that you have, like I have seen so many patients કે તારું કઈ ના થાય હવે દવા ખાવાની છે આખી જિંદગી ખાવ એટલે patient becomes depressed. So we know it is a difficult disease. It is one of the most difficult disease of peripheral vertigo. So we have to take patient into confidence, and then we give enough conservative management. Most of the patients will do very well with conservative management if you have explained them the prognosis for first 6 months, 1 year, 2 years, 3 years. Most of the patients will, first episode would have, when they come to you, mostly they had their first episode 2 years back, 3 years back already, and this is second, third episode. That is when first episode it is very difficult to diagnose that it was a Meniere's disease. Like there are so many differential diagnoses. But once the patient has had 5, 6, 7 episodes, now patient should have a diagnosis of definite Meniere's disease. Now we should not have much of the confusion in our mind and patient's mind. We should investigate him thoroughly, everything, MRI, VNG, ECOG, WAMP, whatever possible, but then we should have a diagnosis that this is your most probable diagnosis. And then if the patient is not getting well with this and he is suffering with his job, with his family life, with his social life, we have to tell him that there are certain options which can make you off medicines. And We will try those options when you are not happy with medicines, when your vertigo is not controlled. It is medically untreatable. And so these are the different surgical options. I consider gentamicin as surgery because we are damaging the labyrinth. So it has to be taken as seriously as you are doing surgery because it is minimally invasive, but it is a surgery because you are making some permanent changes to his vestibular system. So first three I will not talk much. Steroid I have also found it is of no use. There are two different options for gentamicin. Either you give low dose gentamicin, only not more than 2 injections, or you give high dose injections like 2 to 6 injections and with a weekly interval. So both are effective. If you see these patients, effective means they are off medicine. They are off any other medicines. In 60 to 80%, only 1 or 2 injections, they will be completely off medicine for long term. They may have recurrence after 4-5 years, but they are off medicines. And if you give high dose gentamicin, around 90% of them will be off medicines, off vertigo episodes. And in those patients also over long term, they will have 10% of them will have recurrence. So this option has to be given to all patients of Meniere's disease before considering surgery also, any invasive surgery also. Because if, and this is now a protocol of European Academy and most of the academy, that you give them the option of this and this, but this is quite effective, and I usually give all my patients first option of gentamicin, and like we would have given more than 80%, 80 patients gentamicin, and surgery has been done only in 14 patients. So, and out of 80, very rarely only 5 of them came back again after 2 injections. Again they had vertigo, and there is what I believe, it is not documented, but there are some patients who are resistant to gentamicin. We don't know why. And those patients we should tell this is another option. And they are off medicines for 2, 3, 4 years. Then they come back. So they have now confidence in you. Ek baar saro to thai gayo, but now again it has started coming back to something. And then there are these 2 options available with us, depending on his or her hearing, whether if there is complete hearing loss, they may have labyrinthectomy, but it will cause complete hearing loss, no future cochlear implant option, and the success rate of both the options are almost same, 98%. So these surgeries are as effective as stapes surgery. And stapes surgery do have risk. So this also has minimal risk, but the risk is very, very less, that we'll discuss. But if we don't do this surgery, we should not do stapes surgery also. They have also option of hearing aid. But we are taking risk on behalf of patient and making most of our patients very, very happy. So these are the patients who are the happiest patients we have. What are the risks? Less than 2% they have risk of some hearing loss, not complete hearing loss. 10 to 20 dB hearing loss, which does not progress over the time. Gentamicin patients, they will have hearing loss. Initially it will be very minimal, like Darshan Bhai told, but it keeps on progressing. The hearing loss does not stop. It will keep on progressing for next 6 months, 1 year, 2 years. Most of them will come to up to 70, 75 decibel and then they stop. I don't know why they are not going beyond 75 decibel. I have not seen any Meniere's disease who have complete hearing loss due to Meniere's disease. They may have due to some other disease. It stops at 70, 75 decibel because I think the ear has become dead enough that it is not giving again the episodes of vertigo. But these patients, if they come and diagnose at 35, 40, 45 dB hearing loss, you can keep it to that hearing till their life, means till they start developing presbyacusis. But and the durability of treatment is permanent. So this is the only treatment through which patient can go back to his life before Meniere's disease. Patient કહે કે મારી એવી કોઈ આશા છે કે હું જેવો પહેલા હતો એવો થઈ શકું, તો this is the only option with him. They become what they were before Meniere's disease. And the quality of life, like Darshan Bhai says, if he is an actor, politician, doctor, lawyer, judge, એ લોકોને જો ચાલુ ઓપરેશન થિયેટરમાં કે જજમેન્ટ આપતી વખતે ઉલટીઓ થવા મળે ને પડી જાય ને દર અઠવાડિયે 2 વાર થવા મળે, તો their life becomes havoc. It is not an easy life for them. So they are searching for some permanent option. So vestibular nerve section has 3 ways to cut the nerve. You can go through middle cranial fossa, you can go through retrolabyrinthine approach, and you can go through retrosigmoid approach. What I have experience is of retrosigmoid approach, but the other two options are also quite effective. There are experts who does only by middle cranial fossa, and there are experts who does only by retrolabyrinthine approach. But I think this is the direct approach. The middle cranial fossa and retrolabyrinthine approach has some more chances of hearing loss because you are very close to vestibular labyrinthine system. Here you are nowhere close to labyrinthine system, so the chances of hearing loss in this approach is the minimal. What we do is, there are some misconceptions which will come later on, but vestibulocochlear nerve is a single nerve as we know. But anatomically they are two different nerves bundled together with a very clear cleavage line between vestibular nerve, which is located superiorly. This is trigeminal nerve. So superiorly is vestibular nerve, inferiorly is the cochlear nerve. There is a very clear blood vessel demarcating these two nerves. It is called Bremo vessel. The name Professor Bremo was teacher of Professor Manyan, so that is how it is named as Bremo vessel. This is inferiorly the lower cranial nerve, superiorly the trigeminal nerve. So once you enter CP angle, this is the first nerve you come into contact directly. And if you completely cut the nerve, you should not leave partial fibers of vestibular nerve. Otherwise, it will not be complete deafferentation, because what we require is good compensation, and good compensation can happen only if there is complete cutoff of signal from vestibular system to vestibular nucleus. Then everything cerebellum and vestibular nucleus will be doing on their own. We just need to help them by good rehabilitation. So out of 520 vestibular neurotomies which Professor Manyan did before 2008, and after 2008 this is his last paper, and with long-term follow-up of 5 years. And now I have around experience of 14 vestibular neurectomy. None of the patients, like these are the some things which as a surgeon we have in mind. If you do surgery, you will lose hearing, complete loss of hearing, you will have facial palsy, there will be permanent morbidity, you will not be able to live your life. So none of the patients, and when I was in France, this was the surgery most of the Air Force were doing in their training. It was part of their training before going out, they have to do this surgery, who were trained under Professor Manyan. So it is not very difficult, anyone can be trained to do this surgery if they have inclination. So what are the criteria for deciding surgery? First, it should be definite Meniere's disease. There should be no doubt. The definition of definite Meniere's disease, Darshan Bhai has very classically told, it should have all the three components: documented hearing loss, paroxysmal vertigo, ear fullness or tinnitus. There should be medical failure at least of 1 to 2 years, and most of our patients, the mean duration of medical treatment is around 3 years. There should be significant disability of more than equal to 4 grade. Impairment of hearing, because without impairment of hearing you cannot diagnose as Meniere's. And the professional status, as I told, if the patient is very active, he wants to live his life like he was before, this can be the option. If the patient is inactive, he is ready to take some setbacks in life, then it's okay. So out of these 14 cases I will discuss, most of them had at least 1 year of medical therapy, but most of them who were with us, they knew from day one that if medicine does not act, there is another option. That was a very big psychological upliftment for that patient. Patient knew કે આનાથી નહીં મટે તો બીજા ઓપ્શન છે. એવું નહોતું કે this is the only option. Only 3 patients were from Baroda, so patient had to travel from very long distance because they were not known of this available treatment option. So it was not by choice or just they had અથડી ગયેલા ભૂલથી આવી ગયેલા ને, because they were suffering a lot. 5 of these patients had been given gentamicin by ourselves, around 4 to 8 injections with failure. Out of more than 80 patients that received gentamicin, 3 patients were very young. So if they are very young patient, usually the French Academy and everyone has decided in very young patient with Meniere's we should push for surgery more, because the chance of bilateral disease and their active social life is very active. So they have a documented thing that if the young patient, we should consider more towards surgery than gentamicin. 3 of these 14 patients already had suicidal thoughts. Like first patient, when she came to me, they told, "સાહેબ આ આનું ચક્કરનું કંઈ નહીં થઈ જાય તો હું તો સુસાઇડ કરી લેવાની છું." She was so frustrated and she had shown to at least 12-15 ENT surgeons, 10 neurophysicians. She thought that there is no solution to this. She was very fond of ગરબા. I don't know ગરબાના માટે સુસાઇડ કરવા હતા, પણ કે હું ગરબા નહીં ગઈ શકું તો હું સુસાઇડ કરી લઈશ એવું. અને the next ગરબા that she had after surgery was the biggest event of her life. Those patients without gentamicin trial selected surgery when explained the pros and cons of both gentamicin and surgery. When we give gentamicin, we explain that these are the two options available to you. Not બીવડાવવા માટે I personally push them towards gentamicin, but some people have કે ના આનાથી permanent મટી જશે, આનાથી hearing loss નથી થવાનું, તો આ જ કરવું છે. That's all. But I try to push them કે gentamicin લઈ લો પછી પાછું થશે તો જોઈશું. But there were patients who told, nah, we want permanent solution, we don't want any of this shit again. And one patient had CSF leak, but only by resuturing the local wound it was stopped. And that was the early experience of our Mira. Now we have more than 180 cases experience and no other significant post-op complications. So no complication now means never, it's not there. But as I explained, like stapes surgery, if you want to do something for patient has to take risk and you have to take risk both, and most of the patients will be very happy. So some of the conclusion for Meniere's disease is it is a very incapacitating disorder. It is not like other vertigo. It is there are 18% who lose their job, 39% they stop their job, 28% reduce their job activities, and 15% are not left with job because they go and fall down every time. They have to take so many leaves that they are no more offered job. This 43% stop driving, 43% reduce driving, and 14% has no influence on driving. So only 14% keeps on driving as they were driving before. These things appear small to us when we have not lost this independence, freedom. But when they lose their freedom, it becomes too big for them. Vestibular nerve section is the only surgical option which has the highest success rate of all available options. We will discuss endolymphatic sac and others with hearing preservation. And vestibular nerve section is safe for the facial and cochlear nerve. So it is not that we are going to remove her or his vertigo at the expense of something else. Everything else will remain same as it is. Actually the hearing loss also stops going down. It also stops at whatever level it is. So actually the disease stops there. How we don't know, but this is only by long-term studies that they have documented, and vestibular nerve section prevents further hearing loss. So these are the long-term studies of patients with nerve section and without nerve section. So how this is happening is, this is just hypothesis that there is a cochlear efferent bundle passing through the vestibular nerve. It is called bundle of Wood, which passes through the cochlear vestibular nerve into the cochlea. And when you cut vestibular nerve, the signal of hydrops or distension stops going, efferent signal stops going to cochlea. But this is just a hypothesis. We don't know why the hearing loss which was going down stops after nerve section. And the most important thing again, like Darshan Bhai showed, that most of the 20% of these Meniere's disease patients will develop opposite side Meniere's disease after 20 years. So એક તો અત્યારે 10 વર્ષ બગડ્યા જિંદગીના, અને પછી when they are 60, 65, 70 years they start again with Meniere's disease in opposite side. પાછા 10 વર્ષ, અને that last at that old age second Meniere's disease is very troublesome because they cannot walk. With full dose of Verticon also they cannot walk and they require lot of rehabilitation. So somehow unilateral vestibular nerve section is preventing this bilateral evolution. This was a finding which was done by Professor Manyan and his team. Like there were so many papers that Meniere's disease is bilateral, so what we will do when we have cut nerve? So they just went back to their data and they had a questionnaire to all of them that if you had, like now he is doing vestibular nerve section since 1974, so he has enough data. He went back to all the patients with nerve section. Did you have bilateral disease? So the incidence of bilateral disease, normal natural outcome is 15 to 25%. and in their cases it was only 2%. So how it is happening again we don't know, because we don't know so many things about Meniere's disease, but the hypothesis is there is the vestibular nucleus after compensation changes in such a way that it prevents. It is mainly at the vestibular nucleus level and not at the level of hydros, because that is where it is acting. So summary, nerve section, vestibular nerve section is the most effective procedure to treat vertigo. In incapacitating આ ત્રણેય વસ્તુ જરૂરી છે, મેડિકલી અનકન્ટ્રોલ્ડ મેનિયસ ડિઝીઝ. મેનિયસ ડિઝીઝ હોવું જરૂરી છે, મેડિકલી અનકન્ટ્રોલ્ડ હોવું જરૂરી છે, અને incapacitating. All the three things are required to be considered. This is a safe surgery. Like any other CP angle surgery, it is actually one of the safest of CP angle surgery. It is safe for hearing and the contralateral ear. And with that I will just show the video. I don't have the option. So the position is again our autologic position, supine position with head turn and flex. This is the important landmarks, the Frankfurt plane which gives the transverse sinus, and the master tip we draw a tangential line for sigmoid sinus. Then we start the incision for master tip, and 3 finger bit behind the postauricular sulcus we make a curvilinear incision. The incision raises a antero-superior base, skin and subcutaneous flap, and again another incision in a reverse panel which is postero-inferior musculocutaneous flap. So these two flaps will go in as a double breasting to prevent CSF leak. Then this is the most important landmark of our surgery is emissary vein. So we find emissary vein and make a craniotomy of around 2 to 2.5 centimeter around the emissary vein. So here the craniotomy has been made. This is sigmoid sinus. So this is right side. This is sigmoid anterior, posterior, superior, inferior. Usually what we are working is before sigmoid sinus. Here we are working behind the sigmoid sinus. So it is retrosigmoid. So we delineate the sigmoid sinus. We don't need to delineate so much. We can just delineate the posterior margin of sigmoid sinus. And then we make inverted U-shaped dural flap based on sigmoid sinus. Using a 11 number 9, we are making U-shaped incision in dura, which is placed anteriorly. And before we start making this incision, when we start surgery, we should ask anesthetist to do hyperventilation so that the cerebellum retracts spontaneously, naturally. So once the cerebellum retracts, there will be good space between dura and cerebellum, and if you are lucky you will have CSF coming out at this stage, but if not, then we can go inside and drain the cisterna magna. So we go as close to sigmoid sinus as possible anteriorly so that we get maximum space inside. So once we have gone inside, we are protecting this cerebellum with a patty, and all the contents of CP angle will be covered by arachnoid. So these are the lower cranial nerves. This is jugular crest. So we have to dissect the arachnoid so that we can see the cochleovestibular nerve directly in front of us. This is the most standing out structure in front of us. This is the subarcuate artery that we see in our mastoid, which is bleeding. So here we are seeing it entering into mastoid bone. We can cauterize it because it is not providing supply to any important structure. So once you dissect this arachnoid, you get a complete view of the cochleovestibular nerve. So this is less edited, but I cannot go fast, so we have to see this. So we are dissecting the arachnoid by sharp needle and by scissor. And the nerve which we are seeing behind is trigeminal nerve. This is dentist vein, and these are the lower cranial nerves. And the nerve is entering into internal auditory canal. So once you have dissected all the arachnoid, this is the flocculus of cerebellum. So you can see this In microscope it is much more visible, but you can see the line, blackish line, which delineates the vestibular nerve and cochlear nerve. On microscopic view, you can see the curvature also about between the two nerves. So it is much more clear on microscope than this 2D view. This is the Bremo vessel that we were talking. So superiorly is the vestibular nerve, and this is a common vestibular nerve. This is not superior or inferior vestibular nerve. So it has combined and become common vestibular nerve here. The facial nerve which was there behind the vestibular nerve in the ISE has now come behind the cochlear nerve. So facial nerve is protected by cochlear nerve. So once you are behind the vestibular nerve, there will be no facial nerve there if you are in the cisternal part of CP angle. If you are in the ISE, the facial nerve will be just behind the vestibular nerve, but here the facial nerve goes here like this and goes down. So we have delineated the groove between the cochlear and vestibular nerve, and now we are cutting it with scissor. We have to be sure that we have cut all the fibers. We should not leave behind any fibers. So there is some small fibers here. They are cut, and the good thing is if it is cut completely, both the nerves will retract from each other. So the cut nerve will spontaneously retract completely into the. So now see, it has retracted completely. You cannot see that. If you have some fibers remaining, it will not retract. This is just to show this is the nervus intermedius and the facial nerve behind. So facial nerve was completely protected by cochlear nerve. This is the nervus intermedius will come first, and then facial nerve will come. So we have to retract cochlear nerve to see the facial nerve. So this is the end of surgery. Then we have to fill the CP angle with saline because we have drained the CSF, and then our closure starts. So we have this dura, we put artificial dura patch which is slightly larger than the craniotomy to cause additions between the dura patch and the dura so that there is no CSF leak. We take suture through the dura and dura patch, and then we take sutures, intermittent sutures between the dura by 4-0 seal. Unfortunately, we cannot go faster, but only few 30 seconds are using. So just showing intermittent sutures. So there will be some gap between the sutures which we have to seal with free fibrofatty. So these are intermittent sutures. There is dura patch, and these gaps between the dura are the free fibrofatty tissue is kept. We put tissues, the tissue glue, then we put Surgicel, and then we have collected the bone during drilling. So we make bone patty by adding tissue glue to the bone patty. And this bone patty, when we keep after 6 months, they become almost like normal bone. So we had to revise one trigeminal neuralgia, so it was like normal bone again. And then we suture the wound in 2 layers. The musculoperiosteal layer will be anterior and the subcutaneous skin layer posteriorly. So CSF has to find many areas to go, and this is the only learning curve which we had. Like initially, even now we have 5% of our patient having CSF leak, but we don't need to go back everywhere. We just have to take few more deep stitches through the wound, and usually it stops. So just covering other surgeries, as my topic was surgery for vertigo, I will not go in detail because I have not done actually for vertigo. Only there are 2 surgeries we have to do for vertigo, only for vertigo. Other surgeries we do, patient has vertigo but patient has other symptoms like cholesteatoma or acoustic neuroma. They do not come to you for vertigo. Only superior semicircular canal dehiscence and Meniere's disease, these are the only 2 patients they come to you again and again for vertigo. Superior semicircular canal dehiscence we have been trying to diagnose, but we have not found any case. Have you found? Like we have done in suspicious cases so many CT scans, but we are yet to find. But this is again another case where you can heal the patient by surgery and Meniere's disease. Otherwise we do surgery for other symptoms Like in cholesteatoma, we do surgery not for vertigo, but for removing the cholesteatoma for hearing and many other things. Vertigo is a benefit of surgery. Similarly, acoustic neuroma patients do not have vertigo so episodic recurrent. They had only one small episode. So many patients we ask, you have hearing loss, they don't know about it, their hearing loss, they don't know about their vertigo also. They, if you prompt too much, they had a little bit episode of vertigo once, 5 years back, 4 years back. So they never had problem of vertigo. They, I don't know why they are not having much problem of hearing loss. They say that we have hearing loss, but we have shown to 2-3 doctors. Unilateral hearing loss, we don't need to do anything. So only when they start having problem walking, then only they are diagnosed with. So our function, surgery of acoustic neuroma is not for vertigo. For vertigo, we do only 2 surgeries, either for Meniere's disease or for superior semicircular canal lesion. So the surgery can be either corrective or destructive. Corrective when you are treating the cause, which is not possible in Meniere's disease. We tried by endolymphatic sac surgery, but we are not successful. In superior semicircular canal, you can treat the cause, at least you can stop the cause. And others all is destructive surgery, like if patient has perilimb fistula with dead ear and he is having repeated vertigo, then you need to diagnose fistula when they have not had dead ear. Then only you can preserve hearing and you can stop vertigo. But iatrogenic perilimb fistula, like after stapes surgery, we can go immediately stop and everything goes good. But traumatic perilimb fistulas are difficult to diagnose. So destructive surgeries, as we discussed, are these 3. I consider again gentamicin as surgery: chemical labyrinthectomy, physical labyrinthectomy, and vestibular nerve section. And endolymphatic sac surgery has not become famous, as Darshan Bhai showed, because they have long-term recurrence and success rate of 65 to 85%, and incidence of hearing loss. It is considered as a hearing preservation surgery, but it is almost in most of the papers it is between 20 to 35%. So you either damage the posterior semicircular canal or somehow they get hearing loss in 20 to 35% of cases. So this is not a hearing preserving surgery. Other surgeries, corrective surgeries is like cholesteatoma, LSC fistula or multiple canal fistulas, we do surgery. Semicircular canal partitioning, as I told, in superior semicircular canal, it solves the problem, but intractable recurrent BPPV not responding to repositioning maneuvers. I don't have patient any till now, but this is the mentioned indication, so I don't have any video. Sir, you have any? Sir does not have, then we have to wait for 2-3 generations of my life.
2 surgeries of posterior semicircular canal plugging in house surgery.
Yeah, but I don't know, here we are not having, and we are trying to find SSC decision seems very aggressively, like any person telling autophony or trying to hear their eye movement, but
I have SSC decisions.
it is there, but it is compared to, like we have Western literature 40-50 surgeries case series like that.
Actually, in India, most of the SSC decisions is we get in intracranial protection.
Yeah, so those patients with CSF rhinorrhea should have those. Yes.
Because basically what happens is in those people again it is erosion of the skull.
Yeah, continuous pulsation of skull waves and
So a lot of patients with idiopathic intracranial
will have this. So female headache patients.
patients who have bilateral superior canal.
Yes. So there, I have just shown pictures because I don't have any experience. And then corrective surgeries for perilimb fistulas, either traumatic iatrogenic through oval window or through round window. We have to plug it. And then acoustic neuroma removal is actually not a surgery for vertigo, but just to finish the surgeries. And microvascular decompression for vestibular paroxysmia. Again, like most of us think, the diagnosis is difficult to do surgery for such variable diagnosis is till now not permissible to me unless we have a very strong diagnosis. Many of this is there is no doubt of diagnosis. Here the diagnosis is doubtful. Patient improves by carbamazepine if they have paroxysmal, and if you are going inside, then patient has very severe vertigo. If you do only decompression and patient does not recover, I feel I have not done, I don't plan to do also, but if think we are going inside, better to cut vestibular nerve. If they want permanent solution, why to do only decompression? Because these loops are inside the IAC. to go and remove those loops, there are high chances of hearing loss. So if they have very severe vertigo, paroxysmal vertigo, very much, we can do either decompression or nerve section, but I don't have any experience. So that's all. Thank you.
The patient comes to you, and we have to deal with each of those things. Differential diagnostic approach is going to be different. So as sir has just now covered, especially so well for the acute vertigo patient, some cases of recurrent vertigo, the differential diagnosis. We follow a certain approach of differential diagnosis in different. When a person comes to you, the first way we try to put it is that person comes with the first episode of vertigo. Is the person coming with recurrent attacks of short-lasting vertigo? Is the person coming with recurrent attacks of little longer-lasting vertigo? Is the person's main complaint is predominant complaint is of difficulty in walking? Has the person comes with chronic dizziness? Or is the person actually coming with a history of falls? In each of these things, the differential diagnostic approach is different. So generally there is a course that we run, it is called Assessment and Management of Vestibular Disorders course. In that particular course, this particular topic is actually discussed for around 3 hours. Okay. About the differential diagnostic approach. So instead of not doing justice to trying to push in 3 hours of material into half an hour, what I did is I take only one of that. The way we discuss falls, okay, only one of that, and then show it. Provided there is time tomorrow and then there is enthusiasm after 1:30, all the talks are over, then possibly we can stay on that if required, go through the entire 3 hours of session. Okay, that is left in. Okay. So now going to a differential diagnosis, just go through this particular video. I get a lot of videos from all my friends across the country, so I thank them for sharing. This is Dr. Sandeep from Surya. Somebody can make a diagnosis right now at this stage, then you don't need to be here, you can go check in into the hill resort or hill and go for trekking and whatever. So all those things are coming into your mind. Okay, what are all coming into your mind? Huh? You are not allowed to talk. Okay. So we'll come to that. Okay. So Dr. Yash got it. So now what we are going to do now is go through an approach, and then we will come back to each of these things, and after I tell the approach, we'll demonstrate to ourselves how we follow that approach and come to a conclusion in most of these patients. Is that okay? So we'll go to that. When it comes to falls, has there been a loss of consciousness is the question that you have to ask yourself. And the answer to this question has to be determined by you, by the clinician. If you ask the patient, did you lose consciousness, most of these people, even with Meniere's disease, tell, I lost consciousness. Because their way of telling that it has been very bad, where they were just lying down for some time, could not do anything, would simply be consciousness. They would not associate, they don't know the meaning of lack of awareness as it means for us. Okay. So we need to ask the patient to describe the things, go through all those things, and then try to come to a conclusion. But from this description, does it look like the patient was unaware for a period of time? So, because why this is important is the next part of the decision tree depends on whether the patient lost consciousness or not. If the person has had fall with loss of consciousness, okay, or apparent loss of consciousness, generally in the vertigo clinic, these are all examples that I have collected, not from the book, because if you go through the book, there will be so many. From what I have been seeing and what are all the different diagnoses that I have reached so far. Syncope, epilepsy, syncopal migraine and conversion disorder. Okay, these are the four differential diagnoses you need to think in terms of when it comes to fall with a loss of consciousness. What about you? All of you stand up once, because already I am seeing some fall with loss of consciousness episodes. All of you stand once. Blood supply to the brain, global means the entire brain, blood supply goes down. But if syncopes are things that whenever you come across patients with syncopal attacks, this is there is a history long going on to their second decade or max third decade. If in the fourth decade, fifth decade, first time onset patient comes with syncope, as age increases, then the cardiac, if it is the first time onset, then the cardiac etiology to the syncope becomes more and more. And also when syncopes occur during exercise or during activity, then the cardiac etiology to syncope becomes more and more. Then epilepsy is one more cause of fall with loss of consciousness. Syncopal migraine is one under-recognized condition for a long period of time before I knew that this condition existed. I was perplexed with some of the patients who have clear history of migraines, also lose consciousness. Okay. Then conversion disorders. I have had multiple patients, okay, during the testing, during the evaluation, then only they fall unconscious, okay, or they fall off, okay, and then for next 5 minutes, 6 minutes, they don't get up, and after that, they get up. Okay, a lot of hysterical conversion do occur in the vertigo clinic. So the general causes of syncope, if it is not cardiac, is like these are the things: board falls, okay, school prayer, okay, the kid. Generally, this is what happens. There is a huge eloquent lecture by the principal going on, okay, and the child is least interested, and then it's very common. Okay? It's very common in the school. The fact that you know this, that there is a school prayer kind of falls that are known, when the parent comes to you, you know that you don't really have to bother much. There is this condition that does exist. You know, waiting in the queue. Okay, bored people have fallen. Okay. Reflex syncope, where one very common type of reflex syncope which we see in vestibular practice is micturition syncope, where patients go and while standing and passing urine, they will have a fall. Emotional, we know in the medical school, all of us in medical college have come across at least one person who has fallen at the sight of blood. Okay. And then at the thought of distressing thoughts or one more thing where people will fall, will just have a syncopal attack. There's a reduction in blood supply to the brain, and they will fall. Okay. Most of these. Now, when it comes to this kind of falls, there are some things which need special emphasis. Okay, limb jerks is something that we keep asking whenever there is a person who has had a fall. So, the presence of jerk itself does not help differentiate between syncope and epilepsy, especially when it is short-lasting. Rather, they suggest there has been a loss of consciousness. They simply tell that there has been a loss of consciousness. That's all. Jerks at the onset of loss of consciousness suggest seizure. Jerks after loss of consciousness and lasting less than 15 seconds suggest syncope. This particular thing, these particular statements come from a study that has been done on medical students. It is called the fainting lark. Okay, the study is called fainting. There are multiple videos of multiple medical students inducing syncope by hyperventilation and then doing a Valsalva. Hyperventilation followed by Valsalva is sure to give an attack of a syncopal attack. Okay, and when these medical students went through this attack of this thing, where they were induced, a lot of them actually showed, they were actually syncopal attacks, but a lot of them actually showed limb jerks. Headache and falls, headache before fall, okay, like I have not been well, I have been having headaches, and then after that I had a fall, that suggests syncope. After recovery from the fall and loss of consciousness, if the person develops headache, it goes in favor of seizure. These are all small points, but a lot of time have come to my rescue in actually pointing to the diagnosis. That's why I'm including one. Eye deviation, uprolling suggests syncope, horizontal deviation suggests seizure. Flaccid versus stiff fall. When it comes to syncope, there can be both flaccid and or stiff falls, whereas in seizures, most of the falls are always. It is not a flaccid collapse; it's a stiff fall. Now these are the differential when it comes to with loss of consciousness. We will apply each of these things that we learned here in the next cases that we are going to show. Falls without loss of consciousness, loss of muscle tone, which means here patient is completely aware of what is happening. Patient is completely aware of what is happening. But patient's muscles are not listening to the person's speech. Okay, muscles have a typical pattern is you see in a person who is like in the bus, you see one person who is sleeping, or in the classroom somebody who is sleeping. How does the person fall? The first thing that loses control of the person is the neck, like this. Okay, it is like the person who is in the bus, who is that person who see first way they fall asleep is this one. This is the progression of relaxation, just like the sleep's progression of relaxation. First this one, then the upper lip. Just see, it is finally full sleep that he will fall on the but the first fall is here. So that is the kind of progression that happens, very catastrophic. The recovery is by definition around 2 minutes, but then most of the people, the videos that I have come across, within 60 seconds they are up about, you count 60 seconds in the clock, by after that time they are able to walk like before, like nothing happened. Okay, that is the cataplex. Energetic falls and near falls, these are vestibular. There is a lot of energy, there is a dramatic fall. Okay, this is a very active vestibulospinal reflex. What is happening in vestibular falls is the inner ear or detracts from the inner ear, okay, are telling the spinal muscles, the paraspinal muscles, the anti-gravity muscles, you are not holding the body straight. Okay, they are telling the body, this is the line of gravity, whereas you are holding the body in this line of gravity. Reorient it, but it is asking to reorient towards a false line of gravity, and the person. Very commonly we see the short attacks. If you want to see one vestibular actual fall, the best way to first time diagnose that or see that is after a repositioning maneuver. When the debris goes and falls into the utricle, the person will have one jerk towards it. It also tells the debris has fallen into the utricle. It also gives you an example of that reorientation of a vestibulospinal reflex. There's a lot of energy there because it's a reflex. There is muscle action. That is vestibular. When I say vestibular, you are not talking about one diagnosis. There are again four causes of vestibular falls. Falls related to trivial postural challenges, gait disorders. Like a normal person, if he is walking, suddenly you fall. Then suddenly, while they are turning back, they will not fall. A child starts, the grandchild is running, they are trying to hold the grandchild, they will not trip and fall. But for that small challenge, if they are not able to do, then they probably have a higher level gait disorder. Okay? That patient should be straight away sent to Bhatia.
Okay.
Then environmental causes. Environmental causes, okay, where the flooring is very, very wet floor, there can be carpet that is loose. These kind of things also can lead to. But all these things falls without loss of consciousness. You will proceed into them only after you have done one examination of the person. Vertical eye movements. Okay, vertical eye movements. Okay, if the person's vertical eye movements range is limited, a lot of people will come who are around 55, above 55 years of age. They are coming with falls again. They are coming with bruises again and again. Every other evaluation in the beginning may not be. But if you look at the vertical eye movement, it is very, very limited and it will be progressive supranuclear pulse. So you first do an examination of vertical eye movements and then proceed to this particular algorithm. Okay, so that is how we are going to do that. Now vestibular falls, there are four differential diagnoses of vestibular falls. Madam, you can come to the front and speak. I give you a sofa. You want to get sleep also? Want some tea? Tea? Try. That means yes or no? There are YouTube videos on Indian head nod. Okay, what it means. Lot of foreign people don't understand what our nod means. Actually, I also don't understand. So vestibular migraine, okay. BPPV, Meniere's disease, that is Tumarkin's otolithic crisis, and vestibular paroxysmia. Okay, all of these things can be causes. Okay, Vestibular migraine itself can be a cause of falls. It's very important. BPPV patients, see, very easy. Vestibular migraine, history-wise, you can make a diagnosis. BPPV, you do a positional testing, and if the person turns out to be positive, his cause of fall is actually BPPV. Meniere's disease, you know the history, unless it starts with the Tumarkin's crisis, the Meniere's history, which happens in a percentage of people, their disease actually starts off with falls, and the full-blown picture develops later on of Meniere's disease. Otherwise, if already they are having Meniere's attacks and they come with falls, you know that it is Tumarkin's otolithic crisis. Vestibular paroxysmia, okay, is short-lasting spinning sensations, and then they can come with falls. Okay, here you will get a hyperventilation-induced nystagmus that is positive. You will also see a caloric weakness when you do a caloric test. You will also see audiometric hearing loss. Okay, all of those things will suggest that the person is having a vestibular paroxysmia. So with this kind of background that we had, we will go back to one after the other. Okay, the first video we will see, and now you are going to make a diagnosis. Okay. Just see what is happening. This lady is holding on to that child. Okay. Please let me know when my time gets over, because a lot of videos are there. I just stop it whenever the half an hour is over. Okay. She seems to be happy. She doesn't know what is happening. Now, do you think she is aware, she is conscious, or she has lost consciousness? She is completely conscious. So the loss of consciousness with fall 4 differential diagnosis, we are not even considering. So we are considering the other diagnosis. Do you remember the diagnosis that we need to consider? So that is it. What is happening? She is completely aware. It was not really a dramatic push. It was the muscles failing her. She just sink, and then she fell. See, now also full muscles are not relaxed. Full muscles are not into action. Yes. And if you have a time in place, from the time she fell, it has not crossed 60 seconds by the time she stands up.
Yes.
Okay, within 60 seconds she stands up, and she has been going through this attack since she is 9 years of age. Until now she had not got a diagnosis. She had not got a diagnosis, and she was treated for psychological practice and all. Okay. That's it. Fine, perfect. Okay?
Yes.
So we'll go to the actually, I will just see again.
Yes.
So she is being pushed, okay?
Cries.
So there is possibly vestibular falls. So what are the 4 differential diagnoses of vestibular falls? This is condition of the So there is migraine, there is Tumarkin's otolithic crisis, there is vestibular paroxysmia, and BPPV. Okay. This patient's attack always happens within the first few minutes after waking up. And therefore she was given a diagnosis of migraine, and post-migraine she seems to be happy. Okay, I have one more patient who was doing very well on migraine treatment, but she would always wake up, fall, have similar kinds of falls within 10 minutes of waking up, especially after an afternoon nap. Okay, but then after starting as migraine treatment, she stopped having the falls. This everybody has seen this, right? You all are aware of this. It's a little disturbing and distressing. He's turning the head. The body is rotating. First the head rotated to one side, the body is rotating. And he seems to be stiff or flaccid? No. Was he stiff or flaccid? Was he stiff? Stiff. He was stiff. And seems to be completely unaware. Okay. So stiff fall, loss of consciousness. What it is? So it is epilepsy, and most likely one of the tornado kind of epilepsy. That is the gyratory seizure. No, this one. Again, she did not get a diagnosis for 10 years. happening? Has she been forced to the ground?
No.
No. Is she conscious? Yes. She is completely conscious. So what is happening? Her muscles are failing her. Her muscles are failing. What is the diagnosis? Cataplexy. Okay. Muscles failing her for a few seconds. Okay. Less than a minute. That is cataplexy. Completely conscious, muscles failing. Okay, that's all. This case is from Dr. Kanya. I don't like this design on the floor. On the rooftop it is okay, but on the floor.
Prone forward.
See that? Did you see that, gentlemen? You want me to play it again? Okay. You see that old man there?
Yes.
The dhoti. What is he doing? He is taking, he knows that he is going to sink.
Yes.
And then he falls down. Okay. He knows that he is going to sink. Then he falls down. And then nothing is happening. So he is trying to hold on, which means he knows that I am about to fall. And then he is fallen. And then he is getting, history wise, there is loss of consciousness. Finally, one jerk of the limb. Okay. And then he gets it. Okay. And there was loss of consciousness. Then he gets up. If at all this is syncope, what is the etiology? Definitely cardiogenic, right? That's it, he gets up. Okay. Most probably some of the supraventricular tachycardias, these kind of things. Some arrhythmia could be there. Then he's okay now. He knows that he's disturbed. And there doesn't seem to be a confusion by the way he's moving around and all. Okay. He's quite devastated. But then why is it not going to we have to wait for this to get over before it goes. What's this? And give me the diagnosis. Right now you have to. What was this? What was it? Clear cut to market.
Yes,
Clear cut. That's all. Okay? To market. That is a known case of mini disease. It comes from a JAMA network complication. And he immediately gets up. That is what it is. Very sudden postural reorientation towards a false line of gravity. False, but they think it is right. Okay, so this is a therefore. That is the diagnosis. Somehow this person's fall, though not that dramatic, doesn't that fall in direction, the speed, somehow more match that lady who fell on the in front of the house. Okay, this man, okay, he is the BMW CEO. For the 1 week before this actually happened, he was not sleeping well, he was traveling back to back, all those things, and then this happened. What is likely to be the diagnosis? No, he was completely aware. He is completely aware, he knows what is happening. So we are not dealing with the fall with loss of consciousness. We are dealing with the diagnosis of fall the absence of loss of consciousness. Correct? He seems to be completely, he knows that he's being pushed, he's being used. And then, this is not cataplexy. These persons are listening to you.
Syncopal minds.
Okay. Not syncopal minds, migraine. Migraine. Syncopal means he loses consciousness. How many more time? How many minutes of my time is left? Over 10 more. 2 minutes, 3 minutes. Look at this man. Pentagon, big general. Can't even hold himself. He wants to hold the world. Can you see the progression of his? Is he conscious?
Yes.
Completely conscious. Was he thrown? What happened? Yeah. So what is the guy? So do you expect him to start walking on his own within 60 seconds?
Yes, sure.
Let us see. Always the bystanders are villains. For the next video, I need the volume. Okay?
What is the cause of cataplexy?
Lot of the time video fatigue, sir. Last of the time. There is some central orexin levels that they do, which is a little low. And they respond to SSRIs. Don't look at the man who is talking. I need a video for the audio for the next video. Look at the lady.
Country in the G7 that has a free trade agreement with all G7 countries. Our government, under our Prime Minister and the Minister of International Trade, as diversifying trade, investing in Canadian businesses, making sure that we're creating.
She was blinking, she was cool, she was happy. You can see that look at her, she's blinking and staring a little bit.
Today, Canada is the only country in the G7.
She knows that something is going to happen.
All G7
And likely syncope, but syncope is happening in the sitting position you are always sitting. Sir, your view, sir? Syncope. Maybe cardiac. Okay? Okay. Audio first.
Too many others have discovered that, contrary to the promise of the Affordable Care Act, they cannot keep their current doctors under any available plan. Those failures of the ACA are having devastating effects on the lives of many Minnesotans. Last week I heard from Sherry Sexton about the huge premium increases that she and her husband Vince are facing this year. Sherry and Vince run the Irish Ridge Dairy in Millville. It's been in their family since 1859. They've always purchased their own health insurance. Last year the Sextons paid $1,580 a month for their insurance coverage. This year their premiums will cost them $2,200 a month. And it adds up to $26,400 for policy for $13,000. But despite that awful cost,
Post circulation TIA. You want more evidence that it was TIA? Just before this attack happened, This just because before this attack
The governor
happened.
also sees
This is
the
how.
spill ahead of the
Yes.
speech,
So that is
toppling over. The lawmakers say he's known to be a tough old bird, and
just before this attack. One.
the governor also seemed to take a spill ahead of the speech, nearly
Just before that.
toppling over.
So he had one more short attack,
He's known to be
and then after that he had a slurring attack
Yes.
on all these things. Okay. Look at this. She's trying to force him to stand because they want to record. Because the doctors asked for a recording, but the child doesn't want to stand. He's holding on to it. See, the child is falling. They try to leave her. And hardly the episode lasts 1 minute. That's all. After that, the child is okay. Diagnosis. It didn't last that long, sir. It is very less. Sir? 7 times. But this child was given a diagnosis of BPVC, benign paroxysmal vertigo of child. 7 types of. Fine. So these were about one segment, like how we approach a person who comes with falls. Like that you can approach, like sir, it dealt in detail how you approach recurrent vertigo and also how you approach that first episode of prolonged vertigo, central versus peripheral. Again, Dr. Yash will be talking about BPPVs. Then, so, like, we'll have different conditions that are going to be covered today, tomorrow, all these kind of things. And after that, if something is left, we can always do that. Okay. So, thank you all. Thank you so much.
From entire India. And today, at the place like it, it's almost house to audience. So, as the knowledge expands, as the achievement in the technology, so more and more people are getting attracted in this field. And now the field has got the momentum. And one of the key person who has given this momentum is present here, none other than Dr. Srinivas Rorsala. We appreciate your effort because you make available this VAG device and all these technologies, so which has made the diagnosis easy. And more people are getting interested in this field. Now, straightforward, coming to the most complicated topic of the vertigo field, is the Meniere's disease. Some interesting facts about the history that Prosper Meniere was the first person who was a French physician, and in the 1861 he has described this disease, where he has presented a study paper in the French Academy of the Medicine. This paper has described a constellation of the symptoms like a loudness of noise in the ear, deafness, and vertigo as a single disease entity. At that time, inner ear was considered to be the organ of only hearing. Its role in the sense of which is for the balance system was yet to be decided. But he was the revolutionary paper has suggested that there is some connection between the vertigo and the damaged inner ear. Otherwise, in the 19th century, vertigo was considered to be a part of the cerebral congestion or other pathologies. Also, Prosper Meniere has suggested that there is an intralevel and hemorrhage is the responsible cause for the conservation of the symptoms rather than the hydropic dystonia. When we see the epidemiology of the disease, then there is a wide variation from study to study, that 120 cases per lakh to 218 cases per lakh. And as the age is seen, then it is very evident that in the younger people it is very less prevalent. It is hardly 9 cases per lakh. But as the age increases, so it can be up to 440 cases per lakh. And its highest incidence is between somewhere around in the 5th decade of the life. Gender, all the study agrees that female preponderance is somewhere around 2:1 to the male. In inheritance, if we consider sporadic versus familiar, so most of the cases are sporadic as compared to the familiar is hardly 12%. So pathophysiology, presence of hydropic distension is the central histological feature of the Meniere's disease, but we still don't know the exact mechanism. In 1938, Volpais and others have studied the two
specimen of the temporal bone of the patient who died having the symptoms of the Meniere's disease, and this patient died after the vestibular neurostome. And in both the cases, they have found the hydrophobic distension. And same topic was revisited in 2005 by the merchant and others, where they have studied 107 temporal bone specimens. Out of them, 28 were having the symptoms of the Meniere's disease, and all of them were showing the hydrophobic distension. But surprisingly, in the 19 other patients who were not having the symptoms of the Meniere's disease, they were also showing the hydrophobic distension. So this again challenges the accepted belief that endolymphatic hydrops is the cause of the symptoms of the Meniere's disease. As we all know, that there is a endolymphatic space, perilymphatic space. Endolymphatic space is filled with endolymphatic fluid, and which is surrounded by the perilymphatic fluid. When we see in the cross section, it is something like this. And due to the unknown reason, endolymphatic fluid volume increases, and sometimes it balloons out and maybe bursts into the perilymphatic space. So all the endolymphatic fluid will get drained or leaked into the perilymphatic area. And this is the phenomena which produces the symptoms like a dampness, tinnitus, fullness of ear, or giddiness. Factors responsible for the hydrops, again there is a lot of dilemma that there can be anatomical variation, some infectious or immunological phenomena, allergic mechanism, but all of them are proposed mechanisms. Still, we don't have any proven fact. Similarly, the viral infection considered to be the another cause which may produce the fibrosis of the endolymphatic system and may cause the hydrops. Most recent research shows that there can be the dislodgement of the autoconjugate particles which can block the endolymphatic channel and may produce the hydropic distension. Clinical presentation manifests quite variable with regard to the severity, duration of the attack and its natural causes. Severe rotatory sensation is the first and most debilitating feature of this disease, and it can be associated with the vomiting, nausea. It can last from the few minutes to several hours and sometimes for one full day. And it can be associated with a sense of imbalance which may remain there for 2, 3, 4 days even. And the hallmark of the disease is the presence of the fluctuating and progressive hearing loss. But in my clinical practice, many of the patients don't give the history of the deafness. So you will have to ask again and again. And sometimes if you go for the audiogram, you will surprisingly find that patient is having the deafness and he has not given the history of the deafness. Most of the patients will notice the tingling, tinnitus or ringing sensation in the ears. In the early phases or the early phase of the disease, it's only limited to the episode. But later on, tinnitus remains forever, and patient complains that few of the patients they feel sleepy or there can be a drowsiness. And most of the patients misinterpret this symptom as an unconsciousness, or sometimes their relative gives the history that there was unconsciousness. Again, we will have to be careful that whether it was a really unconsciousness or whether it was only sleepy feeling or the drowsiness. Excessive perspiration. Some of the patients they are having a perspiration with vomiting and diarrhea. Again, this is a little bit surprising, a little bit misguiding feature. I have got the patient, repeated vomiting and diarrhea. I have turned the patient towards the gastrologist. They have got the repeated consultation with the gastrologist and they don't get any diagnosis. And even the gastrologist go to endoscopy and all other procedures, but they don't find any conclusive diagnosis. Similarly, another symptom which is a heaviness of head, which is so immense, so intense to the patient, that again they will give the history that I am having a headache, and again you will be diverted to the migraine rather than an migraine. So you have to be careful that whether it is a heaviness of head or a really headache. Second is loss of variation in the symptoms. First is Kumarkin's. We all know that there is a sudden fall without loss of consciousness, which is due to the acute ventricular dysfunction. It is believed that abrupt change in the automatic input generates an erroneous vertical gravity reference. As we have already seen the video of the third. Nervous syndrome, where the symptoms of the deafness, fullness of ear and tinnitus improve at the time of giddiness. Vestibular migraine, where symptoms of the hearing loss, tinnitus or deafness are not remarkable by the patient, and only he complains of the giddiness. And in the cochlear illness, it's the inverse. That patient complains only episodic deafness or tinnitus, and he never noticed or less likely that he has noticed any symptoms about the giddiness or imbalance. When we examine the patient physically, so most of the patients come to us when he is having a resting phase, means he don't have any acute phase. And at that time, almost all the time, we never go for any type of positive physical examination. When we examine the patient when he is having episode, then there are lots of the things we can find out. First and foremost thing, that nystagmus which is getting away from the affected ear. Progressive vestibular injury may have produced the abnormal vestibular ocular reflex, and we may find abnormal heading pulse test. Patient may have a rotation when we are having a stepping test, as well as some of the patients will show the positive fistula test on the pneumatic otoscopy as well as the positive physioscopy. There are the 5 renowned international society working on the vestibular research have given the criteria for the diagnosis of for the Meniere's disease, like definite Meniere's disease as well as the probable Meniere's disease. In the definite Meniere's disease, 2 or more episodes of the episodic vertigo lasting from 20 minutes to 12 hours, and audiometrically proven sensory neural deafness at the low to mid frequency, at least at the 1 occasion of the giddiness, and fluctuating symptoms of the hearing, deafness, tinnitus, and no better accounted for any other diagnosis. While in the probable Meniere's only missing point is documented audiometrically proven hearing loss. Rest of them remain similar. When we consider the staging of the disease, it can be staged from 1 to 4 on the scale of the deafness. And when we have a functionality scale, then it is graded from 1 to 6, and according to the patient's quality of the life and all that. Believe me, friends, this is the only disease which can make the patient so poor, so difficult in their life. That patient may have, I am having a patient who has left their job. I am having the patient who has not attended any social function since last many years. Because they feel that when I will go to any function and I will get the giddiness, he will be in a very embarrassing position. Many of the patients are having anxiety, depression, they are on the psychiatric treatment. So rather than they are on the anti-vertigo treatment, they are on the psychiatric treatment. If we consider the diagnostic testing, audiometry is the most basic and most important. Most of the patients they show low to mid frequency hearing loss, but some of the patients may show the high frequency hearing loss also. So just we have seen this patient and he was having a high frequency hearing loss. Visceral test is again the extension of the audiometry, where the patient is supposed to ingest the glycerin 1.5 mg per kg. It is mixed with the equal amount of the water, and over the period of 3 to 4 hours, you will get the audiogram of that patient. The test should be done intra-episodically. At the resting phase, it has no value at all. And positive test is considered when there is an improvement of 25 decibels or more on the 3 consecutive frequencies, or improvement of the 16% of the speech discrimination. Vestibular testing, when we put the VNG goggle to the subject of the patient is there having the episode, then it is very clear that nystagmus are beating away from the affected side. But most of the time, patients don't show any type of the nystagmus. But in my practice, I have seen that in the advanced stage of the disease, patient may show some low intensity nystagmus even at the resting phase, which is beating away from the affected side. Here we can see. Video hearing pulse test. In few of the patients, we may find the 4 seconds, mainly in the horizontal canal. But most of the time, most of the patients don't show any abnormality in the video hearing pulse test because it measures the high frequency. And basically, in the Meniere's disease, damage is at the low frequency. So, cephalic test is probably the more sensitive in terms of when we compare with the video hearing pulse test, because it tests the mechanism that controls the low frequency response. So it can be turned positive in the 48 to 74% of the patient. Vestibular myogenic potential, this can be the assistive tool. It is not a diagnostic tool, but it can be the assistive tool. In some of the patients, in the early phase, it shows very high amplitude. And when as the disease advances, so again the amplitude of the band will reduce down, and sometimes it is very low in the affected area. Similarly, the ECOG electrocochleography, which shows very low amplitude when we consider the ratio of the action potential versus emitting potential. So in the affected area, the ratio will be very low as compared to the normal year. Radiology, already Madam has covered many parts, but without nowadays, it is not possible to stem a case of the Meniere's disease without radiological diagnosis. This is very clear. Even if your audiogram is showing abnormal hearing and both investigation, other investigation, but without MRI study or all other investigations which are included in the radiology, I think it is not possible to diagnose a case of Meniere's disease. First, MRI contrast must done just to rule out the other possible pathologies like the neoplasm of the vestibular cochlear nerve, central lesions like the multiple sclerosis, and rule out the central cerebrovascular accidents. Young people should go through the HRCT temporal bone to rule out other anomalies like the enlarged vestibular aqueduct or Moninis dysplasia. Already we have discussed intratympanic use of the contrast as well as the IV use of the contrast to visualize the 3D axial reconstructed inner ear. Here we can see that it is in the image A and B, it is a moderate amount of the hydrophilic distension, while in the C and D it is a severe amount of the hydrophilic distension. Differential diagnosis. If we consider the most important slide of the lecture, then it is this. Before few years, friends, any patient who comes to us and who is having a hearing loss and giddiness, tinnitus, આપણે સીધું કહી દેવાનું Meniere 8-10-12 વર્ષ પહેલાની વાત, કારણ કે આપણે એક જ માણસને ઓળખતા હતા, એટલે આપણે એનું જ નામ લેતા. Now we know that there are lots of other differential diagnosis with almost similar technique conditions create કરી શકે. First and foremost, BPPV. Now, BPPV પણ મિસ થઈ શકે some of the time, or BPPV vice versa is in Meniere's. Because first episode of the Meniere's, many of the time, many of the patients when they get the episode of the Meniere's, they give the history here. When I turn my head, I got the giddiness. Now at the resting phase, you never know whether it is complaining about the BPPV or whether it is having a Meniere's disease. When you put the patient in a deep focus position, at that time only you come to know whether you are dealing with a BPPV patient or Meniere's. Vestibular migraine, I think is the most confusing, and probably that's why you have got the terminology migraine Meniere's spectrum. Also, all the things are very similar between all both these two diagnoses. Even the patients of the migraine, we get the deafness, maybe of the low intensity. Patient of the migraine, we get the tinnitus. Patient of the migraine, we get the giddiness. So all the three symptoms are there. But according to me, patients of the migraine, they get the symptoms bilateral, most of the time bilateral deafness, and as the disease progresses, so deafness will remain from mild to moderate variety in the patient of the migraine. While in the Meniere's disease, it can go beyond moderate, severe, very severe. So this is the most important thing which we need to differentiate, and some of the time we may not differentiate. So we need to give the treatment of all the things together. Vestibulocochlear neuritis, first episode of Meniere's, vestibulocochlear neuritis, both seems to be very similar. Okay, so again, abnormal head impulse stress is the key factor to differentiate between the vestibulocochlear neuritis and Meniere's. Vestibular paroxysmia. We were believing that vestibular paroxysmia is a very short duration vertigo, it's a jerky feeling, and it is just having no other associated oral symptoms. But no, now the study is showing that they are having vertigo more than hours, they are having a unilateral deafness, they are having a tinnitus, deafness can be there for the longer duration, which will not recover. So it will be very simple. Again, we will have to take the help of the MRI to rule out the vascular loop, we will have to take the help of the VNG, which will give us a hyperventilation instead much positive. Vestibular schwannoma, again almost all the things remain same, but MRI will definitely help us to differentiate, and heading first test will be abnormal in the vestibular schwannoma. Perilymphatic fistula, again fluctuating hearing loss, tinnitus, deafness, everything will be there. But here, vamp test will be abnormal. In the perilymphatic fistula, amplitude of the vamp will be so high that sometimes it will go beyond the. So it will help definitely. And cerebrovascular accident, specifically the ICA loop infarct, where the cochlear nucleus involved, patient will be having a deafness. It's the very first symptom, and you will be misguided to the means. So again, it is very very important to have a MRI when we are dealing with the first episode of the disease. Otosclerosis, surprisingly, and one terminology is there, otosclerotic mania, where only conductive deafness is there, but patient is having a episodic vertigo, patient is having a deafness, fullness of ear and all, everything will be there. And when patient is going through the staphylococcus, everything will be wiped out, and there will be no symptom of the mania. If we look towards the management, which is most challenging, conservative, lifestyle modification is the first, then sport restriction, improve the sleep habits, stress management, avoid the exposure to the loud sound, restrict the use of cell phone. Again, nowadays everybody is using 8-10 hours of cell phone. Excessive use of the headphones should be restricted, earpods, loud sound intensity should be taken care. Patient should be advised to have a food which is rich with the potassium, like the coconut water, rice, banana, dates. If we look towards the pharmacological agent, then acetazolamide is the first agent which is to be used. It is to be used around 250 milligram once or twice a day. It is believed that its diuretic effect reduces the excess calorific food volume, and many of the studies in our mind experience also, it is working definitely, not in all the patients, but definitely it is working. But it cannot be used for the longer duration because there are certain side effects after the several weeks use, like the hypokalemia, metabolic acidosis, renal and hepatic insufficiency, and hyperglycemia. Another molecule we can use is the beta-actin, H1 agonist, H3 antagonist. It improves the microcirculation of the inner ear by acting on the pre-capillary center of the striatum vascularis. So ultimately, it normalizes the imbalance between the production and the absorption of the lymphatic fluid. So those can be ranges from the 24 milligram to 96 milligram or even higher, some of the authors recommend. And with the negligible side effects like the gastritis, gastric ulcer or bronchiolitis in very few patients. Other molecules which can be used like the calcium channel blockers like cinnarizine, flunarizine, dimenhydrinate, methylene, prochlorperazine. But they should be used for the shorter duration because of the risk of the extrapyramidal system symptoms, specifically in the older age patients like tremors, Parkinson's disease, and dyskinesia. Intrathecal therapy nowadays they are getting much more momentum for the treatment of the menial disease, and gentamicin is the first molecule which is used, and nowadays we recommend to use a low dose gentamicin. Basically, it's a 0.3 ml of 40 milligram per ml of the gentamicin should be used, and it is believed that it destroys the dark cell of the vestibule and ultimately reduces the production of the endolymphatic fluid. Routinely, it is to be one injection given, then after the interval of the 3 to 4 weeks, second, third or up to 5 injections can be given, and response should be measured with the control of the symptoms and abnormalities of the head impulse. Here, your head impulse should go to the abnormal. This is the most important criteria when we inject the gentamicin. Even we can give the repeated injection of the gentamicin once we have the control, and after 1 or 2 years, patient gets again the recurrence of the disease. We can go for the 1, 2 or 3 injection of the gentamicin. First and biggest drawback of the gentamicin is that we should be very precise about the diagnosis, that we are dealing with the patient of the menial and we are not dealing with any other patient. Otherwise, we are going to cause it to blunder. Another is, it is a ototoxic drug, the chances of the hearing loss is always there. So this is another thing that we should keep in the mind, that patient may have a reduced hearing. So if patient is not having a serviceable hearing, then it's okay. But if patient is having the serviceable hearing, then again we consider the thing. The third thing is that it will reduce down the vestibulo-ocular reflex. The patient is definitely going to have some sort of imbalance. Routinely it recovers after a few weeks. But many of the patients, they don't recover for the several months. And few of the patients, they don't recover even for the lifetime. So kind of imbalance may be there in few of the patients. So here we want to improve the quality of the life by giving the gentamicin. But on the contrary, he will be ataxic for the longer duration or the lifelong. So we will have to be careful. There are certain causes for the failure of the gentamicin therapy. First and foremost, I have already discussed that wrong diagnosis is the first thing. Which is very likely if we are not careful. Second thing is, suppose we have injected the patient gentamicin today, and after few months or few years, patient will develop the linear disease on the opposite side. Again, this will produce a failure of the therapy. And third, wrong drug delivery failure. After the injection, patient follows several times. So all the drug will be going into the extension tube. So we will have to be careful that patient will not follow. Another molecule, another drug is steroid can be used as an intravenous therapy, but results are by no way comparable to gentamicin. So it is less likely to use. We see this not in the routine use. Linear pressure apparatus device, which was used before, but nowadays it is proved that its role is not more than a placebo. So now the production of this device is even discontinued. Otherwise, it was very prevalent in the US. Surgical treatment. There are several surgeries. First and foremost, endoempiric surgeries was used, and it was started in the 1927 by the Portman. And there were various technologies was listed by him, like a simple decompression, shunt, the set and the master space to cannulate the duct. But literature says that this surgery gives a good result in the initial phase, but later on, after 1 or 2 years, there will be a recurrence of the disease, recurrence of the episodes. So now this surgery is losing its popularity. Vestibular nerve section, probably my next speaker, Varunbhai, is going to have a wonderful lecture on this. So pardon to speak this slide. Similarly, labyrinectomy, when the serviceable hearing is not there, then we can use the labyrinectomy with the control. What is the challenges in the surgical decision? Again, nowadays it is a controversial, but unilateral menial disease. When we operate on the unilateral menial disease, then patient will develop the bilateral opposite side menial disease. Then probably the previous surgery may become futile. But there are several papers which are suggesting that unilateral menial disease when we operate, then there are enough chances that it can prevent the opposite side development of the menial. Probably Bhavin will say more about this. Surgery for the hearing restoration. How can we forget the cochlear implant in the present era? Even unilateral hearing loss, we can go for this. Bilateral hearing loss, we can go for this. And it will give the excellent results definitely. Only minus point is cost. So the future of the menial disease. Despite the many advancements in the diagnosis and the treatment in the recent years, it remains one of the most challenging diseases to manage. Underlying pathophysiology has yet to be fully understood. And until then, it is unlikely that optimal and curative treatment will be discovered. So, that's all. Thank you. According to me, one, after 1 month, second, and then third. If I will not get the result at the third injection, I stop. And I reconsider after first injury. Most of the patients are according to in my practice. Most of the patients, 70% of the patients, they should respond in the first injection. And most of the patients, they are having sense of imbalance immediately after injection. Very fast.
You insisted that you must make a diagnosis of mediation unless you have a radiological confirmation. our majority said is something very difficult to.
No, sir, I'm asking for the plain MRI rate.
Yeah.
I'm not saying that we should go for the IV contrast and image in the 3D reconstruction and all that. I'm suggesting only plain MRI rate. Rule out all the other diseases.
Reducing the number of attacks.
I've never got the any type of help with the steroid. I've never. I've used it, many of the patients, but none of them are giving the good result. ना बिल्कुल नहीं, बिल्कुल not at all. હિયરિંગ લોસ વધતો જાય છે, પણ વર્ટિગો જે છે એ જાય એવું કોઈ પોસિબલ નથી. અત્યારે આપણે એવું માનીએ છીએ કે હાઇડ્રોલિક ડિસ્ટેન્શન એનો પછી થવા એન્ડ મેની ઓફ ધ ટાઈમ આપણે રૂટીનલી વોટ હેપન્સ કે આપણે પેલું ડાયગ્નોસિસ મૂકીએ ને પછી આપણે એને જ પકડી રાખીએ છીએ ભાઈ આજે પેશન્ટ આવ્યું એન્ડ વી ટેક મેનિયસ છે, સેકન્ડ ટાઈમ આવ્યો છે ઇફ ઇટ ઇઝ નોટ રિસ્પોન્ડિંગ તો reconsider your diet. See, menias is a very different type of a disease. કે જેમાં બહુ જ આટલા બધા ડિફરન્શિયલ ડાયગ્નોસિસ છે એમાંથી પણ કોઈ હોઈ શકે. બસ પ્રાઇમરીલી તમને બધું જ બરાબર લાગતું હોય. સમ ઓફ ધ ટાઈમ એવું થાય કે પેશન્ટની ઓડિયોમેટ્રી કરીએ ને તો ઓડિયોમેટ્રી છે નોર્મલ આવે, પેશન્ટ ક્લિનિકલી બરાબર લાગતું હોય, પણ આફ્ટર 1 month ત્યારે પેશન્ટ આવે ને ઓપી પાસે અને ત્યારે જયારે ઓડિયોમેટ્રી કરીએ ને તેમ કે અદરવાઇઝ તરત કમ્પ્લેન કરે કે આઈ એમ હેવિંગ અ ડેફિનેશન ટીનેટર. કે પહેલી વખતે એને ડાયગ્નોસિસમાં ન પણ આપ્યું હોય અથવા તો પહેલી વખતે ખાલી એટલું જ કીધું હોય કે આમ હેવિંગ અ ટીનેટર, આપણે એને માઇગ્રેનમાં કન્સિડર કર્યું હોય તો ઓડિયોમેટ્રી જે છે એ નોર્મલ. પણ સેકન્ડ ટાઈમ ઇવન આફ્ટર 1 month ઇવન પેશન્ટ મે શો કે એને મોડરેટ અમાઉન્ટ ઓફ ધ હિયરિંગ હોય, ઇટ ઇઝ ક્વાઇટ પોસિબલ. ટોટલ લેસન લોસ થાય કે કોક્લિયર ડેમેજ તો થઈ જવાય. કોક્લિયર ડેમેજ ઇઝ ધેર પણ એનાથી રિકરન્ટ વેસ્ટિબ્યુલર ડેમેજ is not going to. It is total vascular damage, nothing that is. If total cochlear damage is all the time, what happens all the time is the distension, right? Rupture. It creates the problem. તમારું ઘણા બધા પેશન્ટમાં એવું જોવા મળે કે એટેક્સિયા or symptoms maybe there for the very longer duration. The phenomena that happens, hydropic distension and towards the pedigree. That's why patient is getting the repeated episode of the day. So I think I can hand over the mic to
for surgery. What is your criteria for advising a surgery to a patient of menias? Your indication.
The functionality scale जो है ना, when patient goes to the functionality scales 5 and 6, so જ્યારે patient જે છે આવું બધું થાય છે, he lost his job, he don't go outside, he don't, his life will be miserable. At that time, he should go for the surgery. કારણ કે quality of the life is the most important. But up to grade 4, we can control the disease by the medicine, by the economic gentamicin. અને સરપ્રાઇઝલી સમ ઓફ ધ પેશન્ટ એવા હોય છે કે જેને આપણે દવા લખી દીધી 5-7 દિવસ દવા લઈને પછી નથી લેતા, રિપીટેડ એપિસોડ હોય, આઈ હેવ એક્સપ્લેન ધેમ કે હવે તમારે સર્જરી કરાવવી પડશે. અને એ પેશન્ટ જે છે એ 4-6 મહિના કે ગુમ થઈ જાય, પછી પાછું 6 મહિના પછી આવે એટલે આપણે એમ કે સર્જરી કરાવી નહીં હોય. તો એ કે મેં કાંઈ નથી કર્યું, 6-7 દિવસ પછી તમારી દવા આપી હતી મેં બંધ કરતી હતી. ના, આઈ એમ નોટ ગેટિંગ એની ટાઈપ ઓફ ધ એપિસોડ. હવે 6 મહિના પછી પાછો એપિસોડ થયો હોય એટલું તમારી પાસે ઓલરેડી ઇન્ડિકેટેડ ધ પેશન્ટ ફોર ધ સર્જરી.
એકદમ બિલકુલ કશું ચક્કર ના આવે એવું
એવા પેશન્ટ છે કે જેનું ડાયગ્નોસિસ 2010ની સાલમાં કરેલું છે અને અત્યારે 2023ની સાલમાં પાછો આવ્યો હોય કે મને પ્રોબ્લેમ છે, ઓડિયોમેટ્રિકલી એનું ડેફનેસ ઘણી બધી વધી ગઈ હોય, સિવિયર ટુ વેરી સિવિયર થઈ ગયું હોય, વચ્ચે ક્યારેક બહુ માઇનોર એપિસોડ થયા હોય, પછી કશું જ નહીં હોય, સીધું અત્યારે આવે 10 વર્ષ સુધી પણ રેમિશન હોય.
Okay.
What about?
It will be developed in years.